First, I want to thank Jeff and Starlin for their comments, and now we're going to open up the conversation. And taking the moderator's prerogative, I have a couple thoughts I'd like to start with. Number one is just to start with the small story. As I have told you before, I am a physician by training, and most of us who went to medical school and practiced medicine thought very highly of the profession of medicine and maybe of ourselves. Along comes 10 years later, I join Caremark, a PBM, and it's one doctor, me, and 7,000 pharmacists, no joke, because as CVS came into the fold, here are all these pharmacists and myself. And very quickly I learned and was very humbled by what pharmacists knew versus what doctors knew. And now I go nowhere without a pharmacist in my pocket. But that really does bring up a very important issue, and that is in order to make some of these programs that you saw here work, we have to find a way to very early on in training of both pharmacists and physicians find a new mutual respect. And I think that's one of the very basic pieces that are probably missing in order to move this forward. The second issue is, again, in all due respect to my physician fellows out there, we are in an era that we hear of reducing numbers of primary care. We are already in an era of endocrinology paucity, at least in the Chicago area, trying to get into either an adult or pediatric endocrinologist can be a 6-month to 1-year wait. And if we're here today to talk about endocrinology, we need to figure out a manpower issue to address this very, very serious issue. And herein lies our conversation going forward. So I do have good news for you, Jeff. There is no hospital day out there that's $3,000 a day. So the 6,000 to 10,000, which is much more normal, you only need to have a half to third of those hospital days saved.
That's good to hear.
So that's really good news. That being said, we have Rebecca Killian, who is going to respond in this responder panel representing the healthcare consumer, the person who struggles and deals with and is challenged by diabetes each and every day. We have Dr. Ed Pasella, who is representing the health plans. And we then have our two speakers. The one thing I want to keep in mind, and I'm going to kind of push Starlin a little bit, not only to be a pharmacist who runs this very interesting program, but along with me to represent the employer market. Because as you heard, Starlin's programs are employer-based. And outside of the government programs, healthcare payers actually often equates to the employer. So we need to keep that in mind too. So I want to start out and ask, these are great programs. Who's going to pay for them? All right, and that includes, so in some cases, and Becky, you think you're getting away with not having to have a lot of conversation here, but we're in a world of consumer-driven health plans. And we're in a world where the healthcare consumer, the patient, the member, whatever you want to call them, has more and more times they have to reach into their pocket and become a paying part of this stakeholder group. So for each of you, who do you think should be paying? How should it be paid? Is it a fee-for-service? Is it a value-based, outcomes-based? Let's talk about pay to start. Becky, you've been really quiet, and I know for you that's not easy. So let's get us started.
Okay, can everyone hear me? So I find this this start to be very depressing because I was making a note as we were listening to these really great presentations, and a quote came into my head from Wu-Tang Clan: "Cash rules everything around me," and I find that to be, you know, a really daunting hurdle in this. And the other thing I wrote is that, what we've set up here is a dichotomy of save money versus improved health. That should not be a oppositional setup, and yet it is. So I also worry about, and just so everybody knows, I am a type 1 diabetic, so I live this every day. I'm not just sort of a consumer rep, I'm actually a patient. It frustrates me because I know that even I, who can sit on panels like this, know esteemed doctors, I have struggled getting access to health care. I have insurance. I am well educated. I am well connected. And yet when my doctor, when my endocrinologist, my renowned endocrinologist went on sabbatical, I went for 14 months without health care. How is that possible today? And I'm willing to pay, my co-pays, whatever, to get my and I have that luxury. But when we talk about a diabetic population, how many of those are socio and economically challenged and don't have this kind of, if I don't have access to adequate health care at various times, what hope do these people have? So I don't know what the answer is. I just know that for a patient, it's incredibly, it's a destructive dynamic, and something has to intervene to change that.
Ed?
No, I completely understand, where you're going. We're meeting a number of important issues here that we're going to have to address as challenges. Certainly the cost of health care has become a big issue, but I think, Rebecca's right, that, we don't pay for health care because it's cost effective. We pay for health care because it improves people's health, right? That's the idea. And so we're doing this, health care stuff because it improves people's lives. At the same time, I think there is, a great deal of concern about there are other things that improve people's lives, and so we're resource constrained, and so we have to be reasonable about it. But still, we have to be careful that we don't let dollars drive everything that we do. But the other things that we're running up against here, and will be exacerbated by increasing access to health insurance, is there's an enormous manpower shortage. And this is due to the way that we've trained physicians and how we regulate medical schools, and we probably need to blow up the AMA and start over in some aspects of this. And we certainly, in the short term, could import a lot more physicians from places who do a good job of producing more physicians. And many of them are trained in the Commonwealth system and actually are really quite good. And so we need to think about how can we address some of these manpower shortages in the short term, and especially in the longer term. So those are certainly really big issues. But I think, what I'd like to talk about a little bit here is that healthcare reform generally, and the Affordable Care Act in particular, their result here has been to change relationships. And so patients have a much more intimate relationship with insurance companies now because the employers are kind of getting out in the middle of some of the insurance. There'll still be employer-based insurance for a long time, but many people now are directly tied to insurance companies through the exchanges, both public exchanges and private exchanges. And also they're having a more intimate sort of view of the healthcare checkbook. With the so-called consumer-driven plans, what we're really talking about here is that people have bigger copays or bigger deductibles, and certainly in the exchanges, the exchange-based health insurance, there's some pretty hefty deductibles in some of that, and there's some co-insurances that are pretty high to start with until people hit their out-of-pocket maxes, and so this means that you have to be able to demonstrate the value of a lot of different services now to the individual person, not just to a payer, not just to me, and convince me that it's a good idea to do something. And the relationships between payers and health providers are also changing, and I think that we've seen that there's a really great opportunity here for pharmacists to be a bigger part of healthcare. You can go to other meetings and find that there are terrific opportunities for physician assistants and nurse practitioners and others as well, which will help with the manpower problem. And what this is all getting to is that it's all about relationships, and all of these people do a better job because they spend more time with patients, and they're doing, and they're helping patients understand things better. These are all really terrific programs. And so one of the problems that we've had is that we always look to managed care companies to sort of pay for all of this or hire these people or something along those lines. And in many ways, managed care companies have done this. They provide, disease and case management services, and they hire various sorts of firms or, change payment schedules to allow for certain kinds of things to be billed. But the problem is that it's managed care. It's sort of in the same line as that, the Chinese have a 5-year plan, there's too much management in managed care. And this is probably why we need to pursue accountable care organizations and patient-centered medical homes, because then they can do things that are more regional, things that work for them, they can be more innovative, and they can make the decisions about who to hire and how to bring in, other sorts of practitioners and other kinds of, healthcare programs and things that will work for them, and especially the things that will work for the patients that are relying on them. So what we need is for managed care companies to back off a little bit and do a little less management here, and for providers to come to the fore more. And I think that we're going to see that. That's where healthcare reform has been going, in pay-for-performance programs and outcomes programs, but now especially with providers who are going to be taking more responsibility, but also hopefully receiving more of a reward for having done that.
Just a couple quick, anytime we move away from a fee-for-service type environment, I think is going to be beneficial for, and again, a premise of the ACA, whether you like it or not, is how well do you treat a population of diabetics or other types of things. Right. And so if we think, whether it's nurse practitioners, registered nurses, whatever the pharmacists, whatever the labor level is, that managing this population better and coordinating their care better is going to save money, then I think there are incentives to do it. And clearly under a fee-for-service world, that's not the case. Just quickly, Ultimed, which is a for-profit provider that we're working with, they've decided it's been so successful, their docs are happy, their patients are happy, that they're going to continue this after the grant funding stops, which is, I think, positive. And then finally, I think as far as provider status, I live in California, and pharmacists, recently there was legislation that gave them provider status, as Starlin mentioned. Yes. They were ecstatic. Oh, we'll be able to bill for our services. In this fiscal environment, that's not going to happen. And let me just give you a quick anecdote. We ran a demonstration for CMS on smoking cessation among the elderly about 6-7 years ago. And you'd say smoking cessation among the elderly, but CMS said we own these folks, and there's clinical evidence that if you can get seniors to stop smoking, their cardiovascular risks fall dramatically, even after 40 or 50 years of smoking. The cancers are done, but the cardiovascular risks fall. Maybe this is cost effective. Anyway, they wanted to give doctors $36 for counseling smoking cessation. CMS was adamant we could not give docs a code that was easy, because they would just run with it. And every doctor would bill twice a year, those two codes. So they made them fill out a separate form to do it. And very few doctors filled out the form. Even though we asked patients, surveyed patients after, yeah, my doctor did talk to me about it, but they didn't bill for it. But CMS was adamant of not giving them a code, because they said it'll just get abused. And so the idea that pharmacists with provider status are just going to have a code that they can just bill for, I don't think is realistic, particularly in this fiscal environment. But again, I do think this more comprehensive, how do we manage a patient population? If you look at the Kaisers, the VAs, they integrate, they have retention of their patient population, which makes investment in chronic care more beneficial to them from a financial perspective. Those types of things, I think, will play into pharmacists and nurses and better management.
Starlin.
Okay, so I have to put my government hat on and my employer hat on. So 17 years I ran Medicaid in Illinois under 5 governors. And I did the economic analysis, and I did the long-range disease forecast for the state of Illinois and predicted the bears, the bulls, and the bulge. Okay? Here's what we need to invest in our health care like we invest in our 401ks. So we all don't start out under the auspices of a government plan that takes care of us. And with the new ACA environment, we're hopefully getting more people to enroll in that. employers need healthy people that show up and are productive so that we can produce and be a country, a United States of America country that offers, employment, which increases people to be able to afford insurance, and goods and services. So in order to do that, the employers need to invest in healthy employees. Moving everybody into an exchange, that employer's needs are not going to necessarily be met for their populations, because everybody's population is different. I have 4 major employers in 22 states and 32 different plants, and they're all geographically different. So we need to recognize that when employers invest in the employer base and wellness, that they are going to help the taxpayers in the long run not have 65-year-old train wrecks that walk into their programs, waiting for Medicare to pay for them. So we have a population who's elected not to even join the current ACA, and they're waiting till they get what they get when they retire. We have to be proactive about that, and we need to, acknowledge the fact that employers are there for us to help build a complete 360-degree of healthcare maintenance and health management around that program, because it's like investing. If I put $500 in a stock when I'm 19 years old and I leave it alone and I wait until I'm 65, it's going to give me dividends. And so at 19, I need to be investing in my health so that when I'm 65 or 75, or Jan and I at 85 are going to be kicking it, that I'm not depleting all the healthcare resources because I haven't planned for that health process. And in my opinion, it's a joint, I think government needs to acknowledge employers for making that investment. And I think we can't assume all the train wrecks because we won't be able to afford them from a total global economic process.
That's really broad, though, isn't it? I mean, it's not just, it's not just the government or the employer or the patient. I mean, there's a lot of things. I mean, look, I have a 27-year-old son who's incredibly healthy, fit. It took me untold amounts of guilt to get him to get
Yes.
health insurance.
Yes.
Should have just given it to him as a Christmas present.
Yeah,
And we all
I
have
gave
that.
it to him all right.
Well,
That's what we're telling employers to do, employees to do, is to get their young kids. Every other country, I just came back from Israel. At birth, they're given a health insurance policy. They are
Just like a
enrolled in
life
health
insurance.
policy. Everyone has a basic policy. 90% of people buy up because they believe it's an investment for life. We have a societal thing we have to
Yes.
overcome.
Yes.
And I think maybe to a degree, Becky, that's where you're going.
Yeah, there's a lot of factors that affect health, and a lot of so it's not just having insurance. It's people aware of the impact of processed foods. It's
Yes.
watching your.
Yes.
It's such a broad thing, and and what we're dealing with here is immutable human nature. Short term versus long term. Are you going to save me money? Or are you going to give me improved health? Are you all this we have to. We have to overcome the short-term focus in order to have the long-term goal, and that is so challenging.
So let's think about this as marketers. Let's all put on our marketing hat, because we market ourselves, we market our companies, all right? And in marketing, we know that you have to tell somebody something an average of 7 to 10 times in the right way, at the right time, for them to even acknowledge that they've heard that.
With relevance.
With relevance. I found it interesting in I think, Starlin, it was your numbers up there, that the average person sees a pharmacist 13 to 14 times a year. Bringing the conversation back to using all of our resources in an appropriate way, are we even more so beholden to these other areas that are safety net? There is, whether we like it or not, there is a CVS or there is a Walgreens on just about every corner in America. Whether you are low income or high income, that is an asset. Now, my concern is, and I take us to the next question, is let's think of a world where the patient has access to pharmacies. There are only very few places in the country where that is not the case. That that the providers all play together nicely in the sandbox, like we teach our children at a very early age. How do we communicate? We are already very siloed. The conversation that is occurring today in an MTM or in a program, not like yours, Jeff, because they were embedded in the provider group, but in some of what we're talking about with the pharmacies. How do we now make sure that these conversations, that the data that is pulled, what is the asset that brings it all together, that allows it to have continuity and sharing of information? Any ideas? Because otherwise, we have created potentially another silo.
Anyone else? Al?
We'll have the economists.
I'm going to take a more pessimistic view. I think we have a long history to say that changing behavior over time has been not very successful. So you can preach to patients, don't eat the cheeseburger, they do. And there are meds there, I think, make it very rational for some people to live a lifestyle we may think is not as healthy because there are medications that can ameliorate some of the impacts. And I think for decades, the public health community has argued access to insurance, access to care, that's it. And I think the Oregon Health Study has shown that you give people access to health care, and that's not it at all. I mean, it increases utilization, but it doesn't improve health in a substantive way. And again, coming from an economist perspective, I think we have plenty of evidence to say financial incentives along every domain seem to work. And so I think we have to, mandates are one. I think providing a base health plan for everybody, a catastrophic benefit from birth to grave is, if you want a generous plan than that, then you can pay additional premiums as a result. But I think we have to make it affordable for young people, because right now they do overpay from an actuarial perspective, and that's why they don't want in. That's why a healthy 27-year-old says it's not worth it for me from a rational cost.
It's rational.
Yep.
It's rational. Right.
And so we have to have financial incentives both for the individual and I think for firms. And I think the whole movement towards manage this population and that's how you'll be compensated for is much better than a fee-for-service that says, the more you do, the more you get paid.
Ed?
Yeah, I think one of the big issues that we've had for many years is lack of connectivity. We just haven't been able to move data, information around, get people connected in the right way. And so, it's a great idea to have things go on at a pharmacy counter, but if they don't know what's going on, in your doctor's office or the last time you were in the hospital, then it's in a silo and it's not helping, or the physician doesn't have access to the records that show that the patient actually hasn't filled that prescription for quite a long period of time, And so, one of the things about projects that are succeeding, and some of the projects that you've talked about today, and other projects that you hear about, is that kind of data gets moved back and forth. So somebody's created some way of getting that going, and what we have to do is to continue to make those sorts of connections. And so, physician hospital organizations and other organizations, currently coming together, we've seen this before, doctors work for hospitals and that didn't work and they broke all that up and now we're starting it over again. The big difference this time is that there's a lot more connectivity.
Right.
There's a lot more electronic medical records. They're starting to move these things back and forth. Aetna's made an investment. We own a company called Medicity, which is the biggest health information exchange in the country, and that's the whole point, is to create the pipes that allow for this stuff to get moved around. And so we have a lot better information technology. It's going to take a while to get everything connected, to get people to move the data in the right way and then use it correctly. Boy, that's going to be, because right now I'll completely give you that most physicians are basically looking at electronic medical records as it's a piece of paper, but I see it on a screen. Okay, so we're not using it to its full advantage yet because we haven't figured out how to use, this electronic connectivity and storage of records and being able to move data to actually re-engineer our other processes. But we'll get around to that eventually, I think. So the information is probably the biggest thing that's going to happen. But the fact that we finally got the healthcare organization as a whole moving in the direction of being connected, having the data, and learning how to use it. Big process, long time, but I think that's really where the potential is to improve things.
Becky?
Well, I also think, I've kind of vacillate between optimism and pessimism, but one of the things that, yeah, it's really frustrating, but to me, I think the most expensive asset or resource that we confront for all of us is time. It's immutable. You can't add to it, and you have so many things drawing on it. And to me, it's been frustrating, and this is the pessimistic part, is that I know that in order to engage your patients, I mean, I have a real love-hate relationship with this idea of patient adherence, especially from a diabetes point of view. You can imagine that I have a different perspective on that. But, and I look at time, I said, how do you engage a patient in their care? You have to spend the time, right? And yet that's the one thing nobody has extra of, and it's the thing that costs you the most. And when you look at the way care is delivered now, the focus is on time, and I'm always like, I have a cousin who's a doctor, and he was telling me that in one day he saw 62 patients. I was like, how's that possible? You have to be the worst doctor in the world. I mean, nobody can see 62 patients and deliver any kind of care to them. We got into an argument. But, the idea is, especially with diabetes, where it's not like take this pill every day and you'll be fine. It's a constant involvement over a million variables, most of which are unknowable, and you're constantly working and struggling to manage. And to me, when I'm thinking about the pharmacist, and it's funny because I've never thought about a pharmacist as a resource for me because it's just that person behind the counter who gives me, my box of insulin pens or whatever. And they haven't really engaged me, but I thought, wow, that's if we're talking about man hours, the more people that you can spread across, the more time you get with the patient. But it's not any one person's. The doctor doesn't have to sit with me for, an hour and a half and answer all my questions. I have all these different resources at different points in different venues that I can go to sort of put in a complete picture. I also think that patients who maybe don't have much access to a doctor, and face it, a lot of them are intimidated when they go to the doctor and won't ask questions, but they would ask you a question, and they would say, I had this problem with this pen, or, how am I supposed to, what's your suggestion when, I'm using this vial and a syringe and that's a real problem with me in the workplace? I mean, they can engage in a conversation.
Right.
And, and the active word here is engagement. Because when you have engagement, you have education, you have better compliance, you have better control, patients feel empowered. That sort of starts that spiral up in a positive way. But it's getting over that hurdle of time.
Yes.
So, Starlin, you get the last word out of this group.
Well, first of all, in the information system arena, we need to understand that everybody jumped on this electronic medical record bandwagon, and it's proprietary. So some of the ability to communicate with each other is this group won't communicate with this group because of some connectivity. But that's gonna go away. We've realized that in corporate pharmacy world, they need to learn to transfer their information into for instance, the immunization registries, so that the family practice doctors can get on board and say, okay, good, they got their flu shot. I can put that in my record. Direct communication, unless you're in a health system, is probably in a development process. But I think all the powers to be are trying to work together. We want to share the measure information, and we want to share that we've seen them In our program, I have an electronic medical record that has an option of if the physician wants to directly have their staff log in and pull data off, they can, or I can pull it off and send it to them. I'm married to a physician. We created him in pharmacy school, and we sent him on to become a physician. And now, so I work side by side with someone that says that's not going to work for us in the real world. And so I'm constantly being part of that, and I'm focused, and people like me are focused to integrate this into the system because this has to work. This is the vision I saw in 1976 when I decided to go into pharmacy school and not med school. I wanted to be the medication expert. I wanted to fit in that piece of pie. The time thing, my objective in life and the new world of pharmacy is how can we get you to learn something, 10 things in 10 seconds. And the pharmacy models have got to change, and they've learned that. Walgreens has made a big change. Caremark is getting there. Caremark's more top-heavy and doing more things on a clinical, global aspect, but Walgreens is going out there, and it's a little scary because it's scaring some of the family practice doctors because they're putting nurse practitioners in that get-it-and-go clinics. But that's a step in the right direction toward communication, in my opinion. Because if the more health professionals that we are out in that arena, then we want to establish them. If the goal is to have a continued primary care gatekeeper, then those referrals are going to have to be made.
Super. Well, I think that when we talk about sharing data, after CMS coming out and sharing physician salary data this week, we've taken an interesting step. And Ed, I do hope that no one tweeted that you said that we need to blow up the AMA. That could be an interesting conversation. And with that, thank you all very much.
I haven't belonged to them either.